and we'll just introduce ourselves and say who we are. So my name is Clare Gallagher. I'm one of the Neurodevelopmental Advanced Practitioners who works in NDAS based at the Pines in Inverness.
And my name is Clare, and I am also a Neurodevelopmental Advanced Practitioner working in NDAS. NDAS, for anybody who doesn't know us, stands for Neurodevelopmental Assessment Service.
So thanks for having us here today. We're going to talk just a little bit about what NDAS looks at, what we assess, and what kind of neurodevelopmental conditions we're able to assess in the service, and then we'll go on to talk a little bit more about those differences, particularly in girls. So in NDAS, we assess for a particular range of what we call neurodevelopmental conditions, and those, there might be some that you've heard of and some that you haven't. So the different ones that we look at in our service are autism spectrum disorder, ADHD, which stands for attention deficit and hyperactivity disorder, DCD, which stands for developmental coordination disorder. You might have heard of that called dyspraxia in the past. DLD, which is developmental language disorder, and FASD, which is fetal alcohol spectrum disorder. And if you wanted to know any more about any of those conditions, Clare and I did record a video previously about waiting for an assessment in NDAS, and we talk a little bit more about the different conditions and who might be involved in the assessment. So you can check that out on the YouTube channel.
Yeah.
So for all of the conditions that I just mentioned, they are all part of the diagnostic manual that we use to deliver and consider diagnosis and assessments. And it's called the ICD-11. So that stands for the International Classification of Diseases, and it's the 11th edition. And they all fall under the umbrella term or the parent term of neurodevelopmental disorders. So they can all be categorized in that way because they're all brain-based or neurological changes that occur in the developmental period. So that means that we need to evidence that we've seen these differences and these changes in childhood, in that developmental period. And this is really what sets these conditions apart from other conditions, such as things like mental health conditions, which might occur for the first time out with that developmental period. So you might not see some of these things until your young person or your child is a teenager or older, which would put them into a different category. They're not developmental in that way. But we're going to cover a little bit more about that later on in this session.
Yeah, and as Sarah has said, in NDAS, in the assessment service that we both work in, we're kind of in the business of assessing for and diagnosing neurodevelopmental conditions, and we will use the ICD-11 to help us make a diagnosis. So there's all sorts of different criteria depending on which condition you're looking at that needs to be fulfilled in order for a diagnosis to be made. And those criteria are quite strict, so we need to know that we've definitely got evidence for us to make a diagnosis. However, there's also room within that criteria for a continuum to exist, because all of our skills exist on a continuum. So my skills are not the same as Sarah's skills, and your skills will not be the same as your children's or your partner's or anything like that. So it's important to remember, at the very beginning here, that all of our skills exist on a continuum, and neurodevelopmental differences will exist on a continuum as well. And you've probably had the experience of meeting more than one child with the same diagnosis, but they present completely differently. And that's because within the diagnostic criteria there is room for that. There's room for a little bit of variability. And there is variability among the children that we see that meet criteria for a diagnosis. And in particular today, the variability that we want to address is the variability between the presentation of boys, and which is what we kind of consider to be more of a classic presentation that we all know a lot more about. And then what we're hoping to put more emphasis on today is the presentation of girls, which which we'll talk about in more detail next, but up until now has maybe not had the publicity that it deserves, and we're just starting to find out more about that.
Yeah, absolutely. So I guess following on from that, one of the things that we wanted to just touch on is probably quite maybe a big question mark in a lot of people's heads, and it is a big question, and it's about are there more neurodevelopmental differences in boys than girls, or are there is it a true mismatch between the numbers? Are there actually more boys that have these types of diagnosis, or is that a myth? So what we thought we would do is just have a little look at some of the numbers that we're aware of. So there's one study in particular that we like because it's been done quite recently, either 2021, I think, in Norway. And it was a really large scale study. So it was a big group. Thousands of people were included in the study, from children right up to adults. And that's the study we're going to have a quick look at. It was particularly looking at one diagnosis, which was autism spectrum disorder, but we'll take that as an example of a neurodevelopmental condition. So they looked at the rates basically of diagnosis. So they took one group, which were age 4 to 10, and they looked at the rates of diagnosis between boys and girls. So in that age group, 4 to 10, there's around 4.5 boys for every 1 girl being diagnosed with autism. Then when you move up to the ages of 11 to 17, there's about 3.5 boys to 1 girl being diagnosed with autism. So it's starting to fall the gap a little bit. But then interestingly, when you look at the adult group, there's about 2.5 men to 1 woman diagnosed with autism. So what that really is telling us is that something is going on with the way that we are either assessing and diagnosing these girls when they're in those lower age brackets, or the way that they present is different, because that's telling us that once you get to adulthood, more women are being diagnosed, and have we missed them? Well, we must have missed them when they were younger, because they would have had autism then. It's not that they acquired it when they were older. And so that makes us kind of think about why that is, and what do we need to do something differently to stop that gap from being so big in the early years.
Yeah, and the answer, I think it's a complicated question, isn't it? Are there, we know we've got this gap in much more boys are getting a diagnosis of a neurodevelopmental difference or disorder than girls are. Is that just because, boys are more predisposed to neurodevelopmental difference? And that I think the answer to that question is possibly there's an element of that, but definitely there's an element of we're underdiagnosing or under-identifying girls in those early years, and that's possibly because, or probably because they present differently, and kind of thinking about that, the academic literature, so kind of the research that has been done into children and young people with regards to neurodevelopmental differences, has predominantly been done on groups of boys. So because of that kind of creates something that we would call a research bias. So all of our diagnostic criteria, you remember the ICD-11 criteria that we were just talking about, that predominantly has been based on research which has been done on groups of boys. And even for Sarah and I, when we're making assessments, and we use some standardized published assessments when we're in clinic, it's reasonable to say that those standardized assessments, when they were being tested, they were most often tested on groups of boys. Yep. And of course, that raises huge problems, because from newer research which is coming out, and this is what we're going to talk about next, we're starting to realise that girls with neurodevelopmental differences present differently. So if girls present differently, but all of our diagnostic criteria and all of our assessment tools have been based on boys, it makes sense that when we see girls, especially in that younger age bracket where we're under-identifying the most, we're missing them because the tools that we have are not sensitive to their presentations, and the diagnostic criteria that we're using may kind of exclude them in some way.
Yeah, I think maybe just to reassure you while we're talking about that, is that any of these standardized tools or published assessments that we would use would never be used alone for those reasons.
Yeah.
We may use them as part of our assessment to inform us of certain things, or how a young person presents in a clinic environment under a kind of standardized assessment, but we would never use them for either for a boy or a girl on their own. So hopefully that is reassuring that if we do use one, we're using it and then using our clinical judgment to look at
that into context.
To look at what we find from that. But yeah, that it is really interesting around where the research has always been based and what that has then told us about how we look at girls. So to move on then, what we might see as some of the differences between girls and boys is kind of really just emerging. So it's a sort of emerging picture about what we think some of the differences might be across some of the different neurodevelopmental conditions that we may be assessing for. So we might, we'll talk about a couple of those differences at the moment and why we think those might be. So if we think about some of the different neurodevelopmental conditions, ADHD, for example, when we see girls with ADHD, we may see them present as more of an inattentive type presentation rather than hyperactive. So I guess the classic picture of ADHD might be like a school-aged boy who's very hyperactive and bouncing off the walls and all that kind of thing. And actually what we're finding is that girls present possibly with less of those types of behaviours. Maybe they're less impulsive, they're less disruptive, maybe in an education environment. And that can then cause them to not be recognised straight away. Maybe their ADHD presents as more of a difficulty with like sustaining their concentration, or being able to listen to instructions and all those kinds of things, but they may go under the radar for those types of reasons. If we're thinking about things like language acquisition, so thinking about maybe like a DLD type assessment, we know anyway that in the normal population, boys are more likely to be late talkers than girls are. So boys are less likely to develop their first words within that kind of generally accepted developmental period of 12 to 18 months. And this is true across languages and across cultures. So we know this already about the normative population. And then what's quite interesting is by the time children go to school, this pretty much tends to even out. And then when you're seeing children and young people, girls or boys, that have language difficulties that have persisted beyond that age, it seems to be a pretty similar split between boys and girls. So that's really interesting to know. And then kind of swinging to the complete opposite of that, the presentation between girls and boys with autism does seem to have a lot of variation. So, for example, with something that we have to evidence in our diagnostic formulation will be something called restrictive and repetitive behaviours. So these are behaviours that we have to see happening for a young person across environments and throughout their developmental period, but they can look very, very different in boys versus girls. So in girls, what we're finding is that they do often, not always, but often appear much more subtly. So rather than doing things like maybe repetitive movements like spinning or flapping or jumping, girls might do things instead, like they might just do the same play routines over and over again, or organize their toys in the same way over and over again. And that is very different, and it can be more difficult to spot. But the most important thing to remember is they will still be there, and they still have to be there for us to be able to evidence that, that this would fit the ASD type picture. Generally, in the normative population, symbolic play and imagination tends to be better anyway in girls than boys. So you do get that split anyway. So we have to be really careful that we're looking at something that's over and above what we would expect for a girl of that age and stage of development anyway. And some of these things that we've just spoken about, maybe boys being more active, more hyperactive, maybe doing movements over and over again versus girls doing more play-based things over and over again. It makes sense because most of these differences are evident anyway in the population of boys versus girls, like across the whole population. Mm-hmm. So it's it's really important that for us, when we're looking at, okay, this girl likes to play with her doll over and over and over again, is that different to what her peers are doing anyway? And is it something that we really need to be worried about? Although these behaviors can be subtle, we need to make sure that they are appearing at a level which we would say is what we would call clinically significant. So it means that the presentation is meeting our diagnostic guidelines to be classed as a restrictive and repetitive behavior, and is impacting that young person significantly more than it would be impacting a peer of the same age or at the same developmental level. Mm-hmm. So although they may be there, they need to be there at a level that, for us, we're looking at that clinically and thinking,
there's a big impact there.
That's something that we need to know about and to record.
Yeah, and I think that's it's an interesting one, because the differences in presentation between girls and boys, what we've kind of evidenced there is that varies even just between diagnosis. So from what we've looked at there, what Sarah was kind of saying is that with developmental language disorder, for example, at school age, the differences between girls and boys, there will be differences, but potentially not significant differences between girls and boys, whereas with autism, from most of the research that we're seeing, there can be really big differences in presentation. So I think that the take home for this is just to know that there are differences in presentation between girls and boys. The degree to which that will be present really depends. But I think it's also to know, that if you are if you're the parent or carer of a girl, and you're seeing behaviours that you don't think fits a classic presentation, that's not necessarily something to be concerned about.
Yeah, because these behaviours may exist on a continuum of typical development that we also know exists, and it's just about making sure that we see the bits that we think actually that's over and above, or that's significantly different to what we would expect in that whole kind of range of typical development, which in itself is large. We're also still learning about what these differences really look like. So it's just that, to be aware of the kind of, yes, there's differences, but also there's a big range of typical as well.
I think we're actually going to talk about that again in a little while, so we'll probably swing back to that. But next, something that we wanted to chat about is kind of a bit of we wanted to do a bit of a terms that you might have heard section, because we know that neurodevelopmental differences in girls are starting to get the attention that they deserve, and this is certainly starting to be talked about much more in the media, and because of that, there's a lot more terminology going around, some of which you might have heard, some of which you might not have, but we just wanted to kind of bring up a couple of these bring up a couple of these terms at the moment and just address them and talk about them, give it a definition as we understand it, although Sarah and I are also in the process of learning all the time.
There's some that are new to us as well, that we think, oh, I've not heard of that one before, and then we find out about it from various different places. So we're in the same boat sometimes.
Yes, very much so. The first term that we wanted to talk about is masking, or you might have heard it being referred to as camouflaging, in girls and women with neurodevelopmental differences. And this is a term that has been created by the neurodiverse community. So it's been created by the public, and it's been increasingly popular in the media. So you may well have come across it. It's important to notice that this isn't actually a medical term, and because of that it's not well researched or well defined kind of in the medical or the academic literature. And that's okay, that's not necessarily a bad thing, but because of that you might hear people using this word in different ways, and that can be a little bit confusing sometimes. So our understanding of masking or camouflaging is generally it can be described as the act of having to exert a really significant amount of effort in order to kind of perform or to fit in social situations, i.e. to kind of like mask your symptoms, if that makes sense, or mask the way that you would act if you weren't feeling an element of social pressure. Now it's possible that women and girls with neurodevelopmental diagnoses are more likely to experience this phenomenon of having to mask, because they tend to be more socially motivated than their male peers, and that's true of the general population as well. If we take men and women across big population-based studies, women are more reliably interested in kind of like social interactions, and men are more reliably object-focused. Again, that's a generalization, but we can say that that's broadly true of the general population. But because of this, girls and women with neurodevelopmental differences might be more likely to be socially motivated, but because of the things that they find tricky, they might be a bit less socially skilled than their peers. So that means that they are really motivated to work really hard to try to kind of keep up or blend into interactions, but that can then be extremely tiring as well.
Yep.
I think one thing that we wanted to mention in relation to kind of camouflaging and masking is that it's important to note that masking, in the way that we've just defined it, is to a certain extent a typical social behaviour.
Yep.
So if you kind of picture yourself coming into work in the morning after a really difficult morning where you've woken up late and maybe you've even like received some bad news just before leaving the house, and then as you get into work you have a really important meeting to go into, like how would you act? Well, probably you would act completely professionally in the meeting, but that would take a significant amount of effort considering the morning that you've just had.
You probably need to spend some time outside work taking a few deep breaths and thinking, okay, I need to pull myself together and get through this meeting and not let people know that I've just been really upset or stressed.
Exactly. So the being able to having the skill, I guess, and it is a skill, to be able to adapt to different social situations, even if that's not how you feel like acting at the time, to a certain extent is typical. It's a skill that we all have. It's a skill that we all have to use sometimes, even if we don't want to. But the way that it's used kind of among the neurodiverse population is that this is something that people with neurodevelopmental differences are having to do a lot. They're having to do a lot more than Sarah or I might have to, for example, and that's leading to them becoming exhausted, which actually leads us on to our next term, which we wanted to highlight, which is something called neurodiverse burnout. So again, I think this is one which is even newer, maybe newer to Sarah and I.
Certainly seems to be doing the workarounds, like a lot.
Yeah.
I see people using this term a lot more recently. But yeah, there'll be lots of people who haven't heard of it before, including us until probably quite recently.
Yeah, absolutely. And this term kind of refers to the subsequent exhaustion and feeling very, very overwhelmed from having to put all of that effort into kind of masking and adapting for different social situations. So all of that will kind of take its toll. That leads to exhaustion, which is referred to sometimes as neurodiverse burnout, and kind of needing to take really long or significant breaks from social interactions, or to isolate yourself, just kind of in order to get back to kind of like state of calm homeostasis.
I think it's probably worth mentioning that I think from what we've read, it's exhaustion way over and above what you might experience just after like a really difficult day at work, or you've been traveling, or like whatever. I think the way that it's being used is to kind of describe this real complete burnout, and requiring, as Claire said, that kind of shutdown, that almost like I need to restore all of my different batteries in order just to be able to function again, rather than maybe somebody who's just knackered after a day at work and is does their evening routine and kids to bed and dinner on and stuff like that, and then is able to carry on with those things. So it does seem to be kind of it's being described in that way, that it's way over and above that. So it's just to be aware of those differences.
But I think this is what we're saying about all of these things, and this is where it is a bit confusing, is that all of these things exist on a continuum. So is it okay for all of us to kind of like mask at times? And the answer to that is yes. But in order for that to be at the threshold, in order for all of these types of behaviours to be at the threshold that we might consider it to be related to a neurodevelopmental difference, we have to look at the impact that's having, and the impact needs to be considerably higher than we would expect like somebody else of the same age and stage to be at. And that's actually, we were just about to talk about the kind of boundary with typical behaviour, weren't we? So I think that that
follows on quite nicely to what we're just about to cover.
Yeah, exactly. Do you want to talk about it?
Can we pause?
Yes.
Because I think I probably need to go and come back just to finish this last bit. Sorry about that slight glitch there. We just had to pause at the end of the last clip. But we are back just to talk a little bit more about the types of conditions we've just been talking about, so the neurodevelopmental ones, and where they kind of sit in relation to some other I guess types of presentation that aren't neurodevelopmental, and just talking about the kind of the boundary between those two. And the first one that we wanted to touch on, which we think is probably relevant to everybody watching this video, is talking about so girls with neurodevelopmental differences versus what we would call like a sort of typical or normative development of a teenage girl. And there's lots to kind of unpack in that in general, but there's a few points that we really wanted to touch on. So one of them, and I have mentioned this, I think just a few minutes before this, was talking about how normative or typical skills and behaviour have a massive range anyway, and is very, very variable. So if you think about your own kind of skills, your own strengths, your own challenges, and they will be different to, for example, your partners or your friends or your colleagues, and that's why we all have different jobs, different hobbies, different interests, different things that we're good at, and maybe things that we have to work harder at, and that is completely normal. So there's a massive spectrum that exists in what we would call typical development, or the typical population. And then thinking about kind of behaviors in general. So all behavior, anything that you ever would see a young person or a child or an adult doing, to an extent is typical or is normative. What changes about that, what makes it maybe a bit more challenging or a bit more unusual or atypical is really the context in which it occurs, or the environment in which it happens, or whether or not it's appropriate. So for example, if I go to wash my hands and there's no paper towels or something, my hands are wet, and I flap my hands, in that context, that's not unusual or atypical or anything like that. Versus a young person or a child or an adult who may do that in a context that wouldn't normally be considered expected or typical, or wouldn't normally be accepted. Similarly, things like people who really like to jump lots and lots repetitively in nursery or in school would be probably not considered typical, versus somebody who's jumping because they're in a gym class. So all behavior comes from a normative or a typical developmental place, but it's about where and when it's used, and the intensity of it too. And that's when they might be described as neurodiverse behaviours, because they occur in contexts in which they're not typically seen, and maybe they are much more intense in their recurrence and possibly very repetitive and things like that. And because we talked earlier about girls having some of these behaviours which might be more subtle than boys might, it means that when girls are maybe engaging in some of these repetitive or restricted behaviours, they look much closer to the normative range that we just spoke about than perhaps boys might. So boys might be very overt and easy to spot because they're doing things that are nowhere, that are not really close to where the normative range would be, but girls might be much closer to that. And example of that would be, for example, I think almost all teenage girls that I've ever known, and include myself in that, we'd say that they've experienced feelings of anxiety, some friendship complexities, maybe feeling a bit out of place in social situations, experiencing difficulties with family dynamics, and all of these things are very much sitting in that normative range, but could spill over when they change their context and intensity and impact. But we need to be very careful and mindful of these things when we're getting to know a young person, or when we're assessing them. And it's difficult because we need to be careful that we're not missing these young girls, young women, because we know from those figures we talked about earlier that a percentage of them are being missed in the early years. But we also, on the flip side to that, need to be really careful that we're not over what we would call pathologizing, not what we would call normal behavior. And by that I mean making a behavior which actually is in that normative range something to be worried about or something to be concerned about, when maybe it isn't. So it's quite a tricky job for us to make sure that we're A, not missing them, but B, also not worrying too much about some of these behaviors which actually probably occur in the majority of that population anyway.
Yeah, and I think that is especially tricky in that teenage girl population, because I think for teenage girls especially, it's a really hard, it's a turbulent time. It's really tricky, lots going on, lots to navigate around social relationships, all of that type of stuff, and that can be extremely difficult. But be within what we would consider to be, just kind of like a teenage girl type presentation.
And now having things like social media all the time, and these are things that we're just wow, that would be 10 times, 100 times more difficult even than it was, before these pressures were introduced as well to sort of girls at that age group. So it's very much for us having to be aware of what the the societal pressures are anyway on girls of that age.
Yeah, and saying what is that boundary between, is this at an intensity that we would say actually, most of this, child or young person's peers wouldn't behave in this way for their age and stage. And I think for girls that present that bit more subtly, that's where the challenge really lies.
Yeah.
And that actually can lead us into some other types of difficulties as well, which we wanted to chat about. And those are difficulties in something that we would call differential diagnosis. So that's identifying whether a girl or a young woman presents in a certain way because there's a neurodevelopmental condition that we need to diagnose, or is it that there's a different type of condition that we need to diagnose. And one that often crops up here is kind of like mental health type conditions, or maybe just the impact of life experience or the impact of family trauma, and those types of things. And I think when families meet us, they're often quite surprised about how much we really ask about early life experiences, significant life events, all of those types of things. And that's because we know that these things have an effect on brain development in lots of different ways. So if a child has experienced adversities, or has experienced significant loss or trauma or anything like that in their life, this can have a really significant effect on their behaviour. And sometimes the effect that has on their behaviour can look like a neurodevelopmental condition. So when we're assessing a child or a young person, we have to be very careful and take into account the impact of those early life experiences, and kind of look at all of that very holistically. Now that is true of everybody. That's true of girls and boys, men and women. But I think what we've been saying in the context of this presentation is that because girls and women can have that presentation, which is that bit more subtle, which is maybe that bit closer to what we would consider the continuum of what would be expected in the general population. Anytime a presentation is more subtle, that also means that there's possibility for more overlap with other things. So I think in terms of boundaries not just to normative behaviour, but boundaries to other conditions is something that we're always thinking about a lot for girls and women.
And we work really closely with, we have a clinical psychologist as part of the NDAS team, who, any of the cases that we feel require like that really close look at the boundary or the differentials between those types of conditions, that we're really lucky that we have a really skilled colleague to bring into assessment or to approach for consultation around those things. So I think just to be aware that sometimes we might say that we're going to discuss that with our colleague, or we're going to bring her into assessment, and that's why is because she's really skilled at supporting these types of differential diagnosis and assessment.
Absolutely. And then our other colleagues would be in a different service called CAMS, which many of you have probably heard of, but that would be the Child and Adolescent Mental Health Service. So I think lots of people often get a bit confused between NDAS and CAMS.
I think quite a lot of the time people wonder if we are part of the same service, or if we're part of CAMS, or CAMS are part of us. But no, they're a completely separate service, although a lot of young people who maybe are referred to one service, there'll be overlap between maybe, there'll be discussions about where the best service is to see that young person, and those decisions are made on an individualized case-by-case basis.
Yeah, absolutely. But that could be a possibility, and potentially higher likelihood of that possibility with women and girls is that a child or young person might be referred into our service for behaviours or difficulties which seem to be presenting as neurodevelopmental in nature, but after we have a look at the information, or maybe after we meet them, we decide that actually we think that would be better placed to be assessed by our colleague colleagues in CAMS who are experts in the things that we've just been talking about. So things like like mental health conditions and impact of life experience and all of those types of things. So again, as Sarah said, case by case basis, but that's something else that that we're very mindful of, especially for girls.
Yep. Great. Okay, so that actually brings us to the conclusion of this session, and we hope that we've maybe answered some of your questions or thoughts that you had around what the neurodevelopmental differences are, or what they look like in girls. Probably, the biggest thing to mention again is that this area is still relatively under researched, and we're still learning a lot, although we're really pleased that that seems to be changing and that more research seems to be emerging all the time around what we know about how girls and women present in the neurodiverse world. We're going to be running a question and answer session, which we would invite you to submit questions for in advance, and you can do that by contacting Thriving Families or the National Autistic Society, and you can also contact them about the session if you need some details around how to access it and when it is, and hopefully we'll see you there. Thank you.
See you then.